we're going to welcome Dr. George, who is going to give us a presentation on the use of CurQD in the treatment of inflammatory bowel disease.
Thank you very much. I'm going to make a joke. I haven't been this excited since I've had Ali's baklava, and so now we're going to have the talk. Anyway, I was asked to give a little presentation about CurQD and optimizing the management of inflammatory bowel disease. Some historical background. About a year and a half, 2 years ago, I was approached by a naturopath, Nir Solomon, and his colleague, Shimron Ben-Oren, who's at Sheba Medical Center, on the use of this herbal or nutraceutical compound to treat ulcerative colitis. They talked to us for a couple hours, and Asher and I, and we listened, and I knew they were coming to the United States to try to use this new medicinal route. And I first started using it in basically my sickest or most refractory colitis patients. And I'm doing this 31 years now, so it's not like I'm a novice. And sure enough, some of my more refractory patients responded. And I was actually, intrigued and shocked because I just didn't know what else to give them. So anyway, now we're a little bit advanced beyond that point, so we do have some data that we could talk about. So this is a nutraceutical adjunct therapy that can be used to optimize the management of inflammatory bowel disease. I use it much more in ulcerative colitis and in Crohn's disease, but it's a gut-directed combination of curcumin and quinidine or quinidine, which is an indigo naturalis, in specific ratios to treat inflammatory bowel disease. Both of these compounds have been used separately to treat inflammatory bowel disease with studies mostly in the Far East. And this company has this proprietary combination therapy called CurQD at different doses and different ratios to treat IBD. So in a retrospective study of about 88 patients, they showed that CurQD as add-on therapy increased the outcome of their patients with active inflammatory bowel disease or active ulcerative colitis despite pharmaceutical treatment. And these were patients who had been on mesalamine steroids, and about 30% of them were on biologics and were refractory. And as you can see, they reached their clinical endpoints with clinical remission, clinical response, and improvement in biomarkers, fecal calprotectin, as early as 2 weeks, but in the study looking at week 8. They then did a randomized placebo-controlled trial out of 2 centers, one in Israel and one out of Greece, with 42 patients. And these were, again, very similar patients, mesalamine, steroid, and or biologic refractory. And they used a co-primary endpoint, including not just clinical assessment and clinical remission, but they also had to have either improvement in calprotectin or improvement in their Mayo score. And about 50% of them had met this co-primary endpoint at 8 weeks. And just for you guys to know, this study cost them $60,000. So try this study in America, it's probably a little bit more expensive. So what they also looked at was reduction in urgency and rectal bleeding, and as early as 12 days, they saw a marked reduction in with no rectal bleeding or no urgency as fast as 12 days. So theoretically, the way CurQD works, the way the Quinidine works, is it activates the aryl hydrocarbon receptor, which is a gut mucosal receptor that then goes into the cytoplasm and promotes the production of multiple different cytokines involved in healing of the mucosa. It does not suppress the immune system, and they've had multiple different experiments to show that this AHR receptor is activated when giving CurQD. And what they showed in this slide is before QD and after CurQD, activation of the AHR receptor in patients exposed to the compounds. And if you looked at patients with inflammatory bowel disease who were in remission, who were not exposed to CurQD, which is the slide on the right, they do not have activation of the AHR receptor. So showing that it's what they believe is this is the mechanism of action of the indigo compound. And then looking at Crohn's disease, and I have not used it extensively in Crohn's disease, in their initial studies, they're also showing response in Crohn's disease, and they're showing that there are elevated expression of the AHR receptor in both the small intestine and in the colon. And so this receptor is throughout the intestine. Pediatric data also has looked at, again, and these studies are about 18 to 20 patients, a significant clinical response in CurQD in patients, again, failing biologics and other medical therapy with response rates in both calprotectin and the clinical remission score in pediatric patients. And looking at by week 3, about 35% of patients were already in clinical remission, and by week 8, 70% of patients were in week 6, 70% of patients were in clinical remission. So Jellianne and I looked at my patients, and these were patients who were refractory to biologics and small molecules. So these were patients who were already on our available biologics and small molecules, and my first patient that I tried it on was on tofacitinib, and was failing that, and I actually had nothing left to give this person, and put him on CurQD, and within 2 weeks he was clinically in remission, scoped him, and he was a Mayo 0. So it was remarkable that this responded. So we just did sort of a retrospective analysis, chart review of my patients, and again, same sort of data. This was not a controlled study, this was just a chart review, but again, somewhere between 50 and 60% response rate to this molecule that I had never used before. And these were in patients who were biologic or small molecule refractory. So these were advanced therapy patients that were refractory. And again, I'm not the only one who's seen this. We've seen this response at University of Chicago. So David Rubin saw this response with his patients before and after CurQD. And in an open label study out of Czechoslovakia, they decided to use CurQD in combination with Entyvio to see if they could boost the response rate of Entyvio. And this was about a dozen patients, and by week 12, there was an 82% clinical and biologic remission with the combination of CurQD with Entyvio in this open label study. So the protocol's changed, but the protocol is that they give that the company gives a gut-directed combination of curcumin and quinidine, and for the sicker patients, it's more quinidine, and the dose is about 500 milligrams of the quinidine and 1,500 milligrams of the CurQD. They've actually changed the protocol, and they don't start with the red or orange protocol anymore because there have been patients who've had what they believe is allergic reactions to the quinidine, resulting in abdominal pain and in a small percentage of patients intussusception. So what they believe and what they've worked out is it appears to be an allergic reaction to the quinidine, which causes an eosinophilic infiltrate theoretically in the terminal ileum, which causes congestion, and then intussusception via that mechanism. So there's been a handful of cases of intussusception. I saw one myself, and we just treated him expectantly with IV fluids, and it resolved. And I know that they had one here at Mount Sinai. The patient was already sick and underwent colectomy, but you guys can, talk about that. I don't know the case myself.
We will discuss
Preview,
this
next month at IBD Root.
case. Yeah, we will discuss this case.
Okay.
next.
So there's been over 16,000 patients treated worldwide with a lot of data on this compound. And the question is, where do we incorporate this into our IBD practice? Do we do it before we give advanced therapy, before biologics, after patients who are failing mesalamine and steroids? Or do we give it after escalation to advanced therapy for people who are already failing, who you might not want to switch to biologics, who've run out of other options? It's not an immunosuppressant. We are using it, I am using it as adjunct therapy. I'm adding it on to already existing therapy. I have used it as monotherapy in some patients who are intolerant to mesalamine before going on to more advanced therapy. And I see the same kind of results. 50-60% of patients respond and have clinical and evidence of remission by calprotectin or by scoping them. I think it's a novel therapy that warrants more investigation. I think we already have a grant to investigate it further. And I think it's intriguing because it doesn't suppress the immune system. I think we all know that there are medicinal properties to a lot of natural herbs, and the question is, how do we use them in our clinical practice? So somebody said to me, well, how do I use this in my clinical practice? Well, we do our typical clinical assessment in patients. We refer them to Evan Nature, to either the website or the app. Once they start the protocol, I follow them up within 4 weeks, and usually I try to get a fecal calpro before and after starting therapy, just like you would with any other agent that you're following the patients with. I tell patients, and it's on the box right now, if they develop abdominal pain when they take it, they should stop it immediately and not take any more doses. So they're warned of that, and now there's a label on the box that says, if you develop abdominal pain, stop the therapy, just because of that possibility of a dissection. And
Can I ask a quick follow-up question? Which labs at 4 to 6 weeks, and what are you telling them are the risks other than intussusception?
so I tell them that the risk that I've seen most commonly is abdominal pain, that's the side effect I see most commonly, and if they get abdominal pain, they should stop it. With high doses of indigo, used much higher doses in China and Japan, for extended period of time beyond 6 months, there have been cases of pulmonary hypertension. But those aren't the doses that we're using, and we monitor the therapies and lower the dose. And if you feel like your patient's on an extended dose of the indigo portion of the compound, at 6 months or a year, you can do an echo to assess for pulmonary hypertension. And we check LFTs and CBC just like I do with any other new medication that I give the patient.
So I completely agree. This is very intriguing. And actually, you should mention that Ryan just got a big hand from CDMRP to do a control study, Vedo plus CurQD versus Vedo alone. It's a huge study.
Yes, I know.
As far as safety, you are absolutely right. There is something, actually it's a kind of allergic reaction. And
Yes.
the case that we will present next session is illustrating that perfectly with eosinophil and so on. So the question, because there are now 7 or 8 cases that we will report with Sean, is that should we test for possible allergy to the compound prior to start? But the main problem is that it's a delayed hypersensitivity, meaning that it will require to bring the patient, give the drug, and then bring back.
That it's an allergic reaction?
Yeah, I don't know that you can
For
say that.
everybody who
but-
can't hear, the question was, should patients be tested in advance for potential allergy? Because the intussusception complication is thought to potentially be an allergic reaction. However, it's a delayed type
Delayed,
hypersensitivity reaction, so it would be hard to
I think
test.
this is a hypothesis that we have based on the.
Right.
Again, let's wait for the next.
Right, and I think looking at our therapeutic modalities, we see allergies to mesalamine, we see many other side effects from our biologics and small molecules, but yes, this is a
Let's
compound.
just say that natural doesn't equal safe.
Natural
right?
does not
And I
always
had a
mean safe.
patient who
Right.
had microvascular thrombosis, which was unexplained. Patient didn't even tell me she was on Qingdai or CurQD. She had stopped her infliximab, decided she should be on something, started on this, happened to have a colonoscopy, had funny looking, not severe inflammation. I biopsied and got back from pathology. What is this patient doing?
Wow.
And then when I asked the company, they said, oh, there have been some cases of right-sided ischemic colitis. Well, this was left-sided. So I think we need much more safety data.
Right.
I'm gonna have to cut out the questions now, I'm so sorry, because we started late, and I wanna make sure we have time for the 2 cases. Thank you so much, you're not today, every other time. Thank you so much, Kim.